ask the same question. Are we ready for another pandemic? What is happening to the COVID situation prevalent in Mumbai? What is going to happen to the second wave? Is there a third wave? So there are many, many questions. This is something that nobody had even dreamt of, and nobody knows what holds for us in future. So this would be a great moment for us to discuss and try and get solutions, and also what the reality at ground levels were, are, and would be. And none other to discuss this than this very eminent panel. May I, on behalf of Mumbai First, welcome you all, especially the esteemed panelists, Dr. Gautam Bhansali, Dr. Abdul Samad Ansari, Mr. Kiran Dighavkar, uh, and of course Swapnil Parikh. And I must also thank Arun Kumar for being here, and also who will be moderating this very good session. Before I hand over the baton to Dr. Arun Kumar, let me just very briefly introduce him. Dr. Arun Kumar, who's currently the CEO of Apnale for the last 6 years, empowering the urban poor. He has worked with social purpose organizations for over 2 decades. Through the lens of social justice and non-violence, Arun has engaged with issues of marginalization, both in urban and rural spaces. He develops programs and strengths organizations invested in holistic development of communities on the margin. A student of historical sociology, Arun obtained his doctorate from Binghamton University, United States of America, and has authored 3 books already and several other articles. Thank you, Arun, for coming on the panel, and thank you for moderating the situation that we are in. And over to you, Arun.
Thank you. Thank you, Dr. Mehta. Ashwini, will we have the slides before we start the proceeding of the day so that we have a kind of broad context for everyone to start the discussion? This is a presentation prepared by Mumbai First, which basically gives us some basic data that we might decide to engage with as the discussion unfolds today. Made available in time in our discussion. Somebody from Mumbai First will keep a track of some of these numbers that will perhaps get discussed today. Shall we begin?
Yes, please.
Good morning, everyone. The pandemic hit us over a year ago, and it was exactly a year yesterday, 24th of March, 8 p.m. to be precise, that the lockdown was announced in India. As we speak, over 160,000 people have died of COVID-19. Maharashtra has had close to 54,000 COVID-19 related deaths, of which Mumbai has accounted for over 11,500 deaths so far. The second wave seems to be knocking at our door, or we don't know, it might have already broken in. Today, we have assembled here in this virtual space to discuss, is Mumbai pandemic ready? How resilient we are today compared to how we were a year ago. The relevance of this discussion obviously cannot be overstated. As we saw briefly through the presentation, the death, the destruction have been huge. In addition to a humongous loss of lives, the disease and the lockdown have wreaked havoc on the economy, both globally and nationally. According to one study, 3.2 crore Indians have fallen off the middle class bracket. 3.2 crores. 75 million have joined the ranks of the poor in the last 1 year. Mumbai, I'm sure, will have its fair share of that, as Maharashtra continues to be the state with the highest number of urban poor in India. So without a further ado, ladies and gentlemen, let me bring to you my esteemed panel who have been at the forefront of the struggle against the pandemic. Without saying, we shall approach the subject with a critical eye to learn, to use the challenge as an opportunity to improve, to be prepared better. Let me start with a brief introduction to Dr. Gautam Bhansali. Dr. Bhansali is a practicing physician and consultant at Bombay Hospital Institute of Medical Sciences, Mumbai. He's very actively involved in the treatment of COVID patients. He has been the representative of private hospitals in Mumbai and responsible for arrangements of many beds for COVID patients in these institutions in consultation with the government of Maharashtra. Welcome, Dr. Bhansali. Our next panelist is Dr. Abdul Ansari, MD, ID, CCM, FNB. Studied medicine in Madhya Pradesh and specialized in anesthesia before taking up super specialization in critical care. He has experience of over 15 years ensuring excellence in clinical care and patient outcome. Dr. Ansari is the director at Critical Care Services, Nanavati Hospital. He has been felicitated by Shri Bhagat Singh Koshyari, Honorable Governor of Maharashtra, for the outstanding dedication and selfless service towards the society during the ongoing COVID-19 pandemic. Happy to have you with us, Dr. Ansari. Our next panelist is Mr. Kiran Dighavkar. Mr. Dighavkar is the Assistant Commissioner of the G North Ward and Nodal Officer in Swachh Bharat Abhiyan. He joined Municipal Corporation as A Ward Assistant Commissioner in 2008. In 2019, he received Shiv Sena Pramukh Balasaheb Thackeray Ward Committee Pride Awards. Previously, he was A Ward Assistant Commissioner in 2016 and 2017. I think up to that point, he was in M Ward. He's the architect of what is now well known as Dharavi model. The Dharavi model features a public-private partnership along with community participation. A warm welcome to you, Mr. Dighavkar. Our final panelist of the day is Mr. Swapnil Parikh. Dr. Parikh is a practicing physician in Mumbai and co-founder of DIY Health, an AI-powered health tech startup. His practice focuses on reversing lifestyle diseases like diabetes and obesity. Dr. Parikh specializes in internal medicine. He's a clinical researcher. He has, along with Dr. Rajesh Parikh, Director of Medical Research at Jaslok Hospital, and Mahera Desai, clinical psychologist, authored a book. It's entitled The Coronavirus, What You Need to Know About the Global Pandemic. We could not have dreamt for a much more powerful panel to discuss where Mumbai stands today. So, shall we begin the proceeding? My first question is to Dr. Gautam Bhansali. Before I read out the question, please share everyone who has joined in. Welcome. Please share your questions and comments in the chat box. I would also request all the panelists to ask questions to each other if there is any question, if there is any suggestion. The idea is to discuss it collectively, because what we are discussing is basically how the city, how a collective is ready, or what needs to be learned from the last 13 months experience. So I'll request everyone to participate in the discussion by sharing their questions. The first question is to Dr. Gautam Bhansali. Could you please share a summary account of how we have as a city responded to the COVID-19 situation? What have been some of the most important learnings so far? Over to you, Dr. Bhansali.
Yeah, thank you. Thanks a lot, sir. Thanks for inviting me on this Mumbai First platform regarding this COVID-19. And the thing is that whether we are ready for this another pandemic or part of the pandemic or second wave of pandemic, and how we were prepared for this pandemic in last year. So if I go back to that exactly 1 year back, that time the condition was totally different. That time municipal commissioner was Mr. Praveen Pardesi. I know that that time condition was such a bad that whole world was not prepared for this pandemic at all. And nobody was knowing about the disease so well, and nobody was knowing about the treatment so far about the disease. Everybody was thinking that this is a virus, and this virus is just like a normal pneumonia sort of infection, viral pneumonia sort of. It will go like this. It will normal cold, cough, sore throat, fever, something like that only. Then with that time we came to know, okay, no, loss of smell is there, loss of taste is there. Loose motion is also part of the symptom of this COVID only. So the whole world was totally not knowing about the treatment. As far as treatment is concerned, we have seen almost all medications was tried for this COVID. Like we have tried doxycycline, we have tried anti-parasitic type parasitic drug, this ivermectin, we have tried anti-malarial drug, hydroxychloroquine, we have tried antibiotic, we have tried antiviral Fabiflu, remdesivir, we have tried tocilizumab, we have tried plasma therapy. Still, we are not 100% sure that what we are dealing with and what is the proper line of treatment. Since it's a viral disease, yes, treatment is definitely symptomatic only as far as treatment is concerned. But now we are well prepared with the treatment. We know when to admit patient in hospital, when not to. And the second thing is that patient was also not aware about the disease. Forget about the patient, government, doctors, everybody was not aware about the treatment. Everybody was not aware about the disease, that when to admit, when not to admit. Initial, the time, I still remember that in the month of April, when we were discussing about this pandemic, the whole world was looking about our country, that there will be like, I heard that news in the BBC, and there's a one American foreign expert was saying that if this COVID enter in India, then it will be a big disaster for this country. So we were also not prepared how to go about. That's why that time we developed only one hospital, which was the Kasturba hospital. That was a government hospital, and no private hospital was also ready for this COVID. Because that time there was a lot of talks that we need to create negative pressure, we should have separate entries, separate exit, all the things, all parameters should be different. We should wear PP kit. How we don't know how to wear PP kit. There was a lot of training was going on for the PP kit, how to check patient whether we should use our stethoscope or not at the time of intubation or putting BiPAP or putting any tube, what equipments we should use, we should not use. That all things was going on that time. So initially we were developed that Kasturba hospital, then we started 7-year hospital. Then later on, day by day, there was the problem and the cases was increasing. Then we developed that all private hospital. I still remember there was a big meeting with the chief minister, chief secretary, and the municipal commissioner, and private hospital was, unfortunately, or whatever the thing was there, whatever their problem was there, they was not ready for the bed arrangement also. Because in Mumbai, structure is different. Hospitals are in vertical shape, it's not on horizontal shape. So separate entry, separate exit is not possible for in the city. But it's, and financial problem was also there. But in one simple meeting that time, I still remember Chief Minister Saab was there, Sodhav Saab, and he said only one simple one line. Okay, Dr. Saab, we don't need charity. We want sacrifice from you. पेशेंट्स के बिल बहुत बढ़ रहे हैं, हमारा गरीब मरीज कहाँ जाएगा? हमने हमारा नायर सायन केएम उनको भी हम लोग कन्वर्ट कर रहे हैं कोविड के अंदर, हमारा नॉन कोविड पेशेंट बेचारा कहाँ जाएगा? थोड़ा पैसे का प्रॉब्लम हो रहा है, बिलिंग कम होना चाहिए. दिस इज सेड इन सिंपल वे. We don't want charity, we want only sacrifice. And this is the time, maybe for 3 months, 6 months, we don't know. All private hospital collectively say, yes, we are ready for this thing. We will do sacrifice. Whatever government will reset the rate and all the things, we will go ahead with that. Immediately that time, only 74 bed was there in the private hospital. Within 10 to 15 days, with the 33 major private hospital, Bombay Hospital, Lelavati, Jaslok, Nanavati, all hospital collectively, and we were started 2,600 oxygenated bed and 1,019 ICU bed. With that time, we were knowing that we may require further bed or there may be surge in the month of October, November. So we should develop some jumbo facility. Government was ready for that. We started developing jumbo facility that time. We were not, see, India, the problem with our country was that we have best of the best doctor, best of the best nursing staff, manpower is good, but only lacking was health infrastructure. We were not ready with the health infrastructure at all. We were less with the this ICU setup. We are not having that much ventilator bed or BiPAP machine and this oxygen supply machines. So with that time, that corona or that pandemic taught us that we should develop our health infrastructure. And within a few months, Mumbai is the first city who developed Jumbo Hospital. Jumbo Hospital is the facility where everything, that was a full-fledged hospital. Initially, there was a myth about the Jumbo Hospital that it's only quarantine center or something like that, or isolation center. No, it was a total hospital, except surgical work was not there. Otherwise, ICU, oxygen, BiPAP, all kind of medications, all kind of investigation, everything was there. So with the time, we learned about the things that how to go about as far as health infrastructure is concerned, health staff is concerned. We deployed some doctors from Beed, Latur, where that COVID was not there. We called them from there, and they stayed in some 5-star hotel. They got good food, and they worked very hard in this COVID. So ultimately, at that time, or you can say that in the first wave, we were not prepared initially for 2-3 months, but after that, with the participation of public, private, all hospitals, with the over enthusiastic approach by the doctors, by the municipal commissioner and government, we all prepared for this worst come worst scenario and this pandemic also. Now the thing is that this is the second wave. I told few days back also that this is not a surge. This is second wave. If you see the last 1 year graph, UK, US, Europe, they were all 3 months ahead of this thing. And we were just 3 months behind from that Western world as far as COVID cases are concerned. Just after this time, and just before 2-3 months, there was cases in UK, US, Europe, still they are there. Just after that, cases have increased in Kerala, now in Maharashtra, and I'm sure it will go rest of the country. Only difference between that country and our country is we are ahead in vaccination. Vaccination, we are definitely ahead of that other country, and that's why I urge government and everybody that we should do mass vaccination. We should do surgical strike of vaccination to curb this second wave. That is the only way. But yesterday there are a lot of cases, like there was more than 5,000 cases. Why? Because we have tested approximately 40 to 45,000 persons. So today also we are testing more and more people, and definitely cases will increase, maybe 5,000, 6,000. Yes, this time cases are less symptomatic, or you can say more are asymptomatic. But this time we are totally prepared with the, as far as treatment is concerned, as far as bed is concerned, as far as any health infrastructure is concerned, and people are also aware about the disease. I feel each and every patient knows what is oxygen saturation level. Earlier, nobody knows about the oxygen saturation level. Nobody knows about the blood pressure. Nobody was knowing what is the temperature and how long it will go, or what is the loss of taste or smell, something like that. But now each and everybody is aware about what is oxygen saturation level, when to contact doctor, when to get admit, whether hospital is better or home isolation is better. So this time, I'm sure we are totally prepared with this pandemic. This is definitely second wave, but we have to use four things. One is SMS, sanitizer, mask, social distancing, and vaccination. This is the fourth pillar that we have to adopt in our normal life. We have to see that we have to live with this COVID for another 1.5 years till vaccination program should be there.
Thank you, Dr. Bhansali. It's a remarkable from 70 odd beds to over 2,000 beds in less than a fortnight. And what you said about charity and sacrifice, it resonates with so many of Mumbaikars, because that's what precisely our health professionals, from doctors to the frontline worker, nurses, everyone has done. I mean, their sacrifice is tremendous, and we absolutely salute that. Thank you very much for giving us the introduction in terms of how it all began and what we have experienced in the last 12, 13 months, and how we should now prepare for the second wave, which doesn't look like a surge. It does look like a second wave. My next question is to Dr. Abdul Ansari. In the light of treating severe or critical cases, could you please take us through what you think have been our major learnings? May I also request you to kindly touch upon how the private hospitals have contributed to this collective effort at negotiating this pandemic. In particular, given your expertise, please tell us what the learnings have been in treating severe or critical care cases in layperson's language, of course. Over to you.
Thank you, sir. First of all, I would thank Mumbai First for really leading this kind of an initiative. And this is probably one of the most important ways in learning can be disseminated. And I think we are doing a wonderful task of, revisiting what happened in the last 1 year, so that the next year, and I'm afraid I'm not, a pessimist, but this year also, 21, would be actually a carry forward from 2020. And we need to really consolidate our learning and put into practice. Now, knowledge could be of two types. One is an idle knowledge, which is in books, and the other, which is in practice. So I think, as Dr. Gautam very rightly started with the kind of preface, how exactly we moved in the last 1 year from a meager preparation, which the West was very closely, how we will fail. In fact, we have excelled by God's grace. If you look at the city like Mumbai, having only 11,000 deaths in 1 year, and compare what exactly happened in New York, you know that we have fared 10 times better with facilities 1/10. If you know, there are 33 beds of ICU beds in US and nearly 20 beds in Europe, to a dismal 3 intensive care beds per 1 million population. So this is the reality where we started with. 3 or 4 critical care capable beds in a 1 million population as compared to 30 in US. And look what has happened. So the answer was not in treating. Treatment is a late part. As Dr. Bhansali very clearly said, masking, social distancing, and appropriate COVID-associated behavior is something which is at the heart of stopping this train from gaining the speed. Once this train gains the speed, there is no stopping. And we have seen that. In fact, now I may beg to differ that it's a second or a third wave. That's a notional value, because we started in March with not a big number. We went up to June, July as a real warm-up. There was a slight fall in cases and everybody was a little happy. And then the September wave came. And that was really the peak. So you can call it either June to September as one wave or two small, plateaus. But now we are certainly, after a 4-month lull, seen in March what is really alarming. As we can see, we are testing more, we are more capable, we have more expandable beds, and we are also now, taking care of a lot of non-COVID, disease, which was not there in the middle of the last year. So I think the pressure is far more on us because of the COVID and the non-COVID illnesses together, because people don't want to now neglect the non-COVID. In fact, the most painful part was that there are a lot of malignancies which cross stages. because of delay in their treatment. A lot of other non-infectious diseases actually were snowballing around. So I think when we come back to today's situation and the learning that intensive care as an intensivist we had, number one was a very important focus on training of our healthcare workers about, as Dr. Gautam said, about the donning, doffing, creation of isolation areas, having intensive care beds, monitored beds, step-down units, and general wards, working as a team. And the same thing which was adopted by the city and the municipal corporation by having war zones, war rooms, distributing, delegating work, started making us much more coherent and cohesive as a force. And probably that's the most strongest point that Mumbai showed to fight this disease against all odds. There was an organizational structure which was at work, led by our municipal commissioner and our chief minister directly, who ensured that the hospitals, private hospitals, jumbo centers, and government centers were working together to their own strengths, knowing their weaknesses. So I must tell that private hospitals played a very important part. And Nanavati Hospital Radiant Group, right from the beginning, was ready to take the lead. We had nearly 150 beds at a point of time, with more than 35 critical care beds amongst those 2,000 beds. And I must very happily tell that we treated more than 6,000 patients in the last 1 year. Of that, we nearly treated more than 2,500 critically ill patients, and with an alarming low mortality of hospitalized patients to below 6%, with a 92 to 93% recovery, which was, I think, very commendable when we look back. And together as Max Healthcare Group, we looked at 17 hospitals across the country, treating more than 25,000 patients, with again a similar 92% of recovery rate and a mortality ranging in 5 to 6% of hospitalized. So I think the learning that we as intensivists was that identify and triage early, use digital platforms, use your e-ICU capability, and allow your empower your junior consultants, clinical associates, and intensivists to lead from the front, to take care of the whole triaging of the patients when they come to the intensive care, to the emergency department. Immediately triage who goes to a monitored care bed, who goes to a plain bed, and who goes to an ICU, and use the turnaround time to your advantage, because most of the ICU patients may stay for 10 to 15 days. So you need to move them out as the oxygen requirement comes down, because the critical care resources are always sparse. If you look at today, we have probably 500 critical patients in Mumbai, but I would beg to differ and say that maybe there are 2,000 potentially, unstable patients. And those are the 2,000 patients who will actually, if taken care of in the right manner, will reduce your mortality. The other number of patients, as we say, there are 365,000 cases overall, and among them, there would be probably not more than 5,000 patients who will be really the red hot ones, where we need to timely provide the care. Number two, rostering of healthcare workers is very, very important. And I think, as Dr. Gautam said, that we need to really understand a way in which we could use our healthcare workers without tiring them out, also maximizing their work, work potential. We had to create systems where they could be, kept away from their family, can be transported very carefully, can be given offs so that they can come back. And last but not the least, I think of understanding the clinical treatment protocols. As over the last 1 year, we realized initially there were no antivirals to come in. After a couple of weeks, we got the first antiviral remdesivir as well as favipiravir. We were using initially repurposed drugs, which were like doxycycline, azithromycin, hydroxychloroquine, which were not really effective. And then somewhere in the middle, we realized that using steroids in the patients who are having oxygenation deficit was definitely advantageous. And then using other drugs for blood thinning, that is anticoagulation. So I would say the three-pronged approach for COVID was the most important learning message, where an antiviral coupled with the need of steroid in an adjusted dose depending upon the oxygenation requirement, and an anticoagulation. This was actually the most important learning message, which reduced our mortality. And number two, providing non-invasive support as much as possible, rather than jumping on invasive ventilatory support early on. In fact, the West has learned to their peril the fact that going early on invasive ventilation can be harmful. You are burning your resources, you are not getting a great output, and then struggling even with a better number of ICU beds doesn't help. So what we realized was that providing oxygen to most of the people with other supportive therapies were more beneficial than straight away jumping into invasive therapies. Last but not the least, uh, we started recover clinics to look for what was happening as the patients got better, went home, and a lot of them came back. Nearly 17 to 25% of the patients were coming back with some kind of post-COVID sequelae. And a lot of them actually had come back with fibrosis, with breathing difficulty, with strokes and new events. And last but not the least, we also realized that non-COVID work needs as much of care, and you need to have a hospital and a hospital approach. And that's something simplified everything. That in a big hospital or any hospital, you need to have a COVID specific area and a non-COVID area where the workflow goes seamlessly without any kind of interaction, and you isolate each of them. And in the interest of time, I'll just close it by saying that we need to be prepared to ramp up our capabilities of opening up more isolation, monitored and critical care beds. And this will be the learning which will stay with all healthcare facilities, that be capable of ramping up your capabilities, converting your beds, normal beds, into monitored or critical care beds if required, keeping your buffer healthcare workers on your roster, and always be prepared for a similar infectious emergency. Thank you.
Thank you. Thank you, Dr. Ansari. It was very insightful, very informative, and also very reassuring. A layperson may not know what all goes in behind the doors in terms of confronting, combating this pandemic. We'll come back to you, and there's questions about learning, training people, training personnel, questions about data that we'll engage with. But for the time being, let me now proceed to our next panelist, Mr. Dighavkar. Mr. Dighavkar, could you please recount some of the most critical steps undertaken by the MCGM to tackle the pandemic? Is Mumbai equipped today?
First of all, I'm really sorry that I could not join on time because of fantastic traffic jam in Dadar itself. And I just joined. Sorry for whatever the embarrassment it has happened.
No issues, no issues.
To start with, I'm sorry, I have just joined. So I just wanted to know, you're asking about the entire pandemic situation or the recent second wave which is coming. So you are asking about the same or just?
No, Mr. Dighavkar, we are starting with a very brief summary from you about how the MCGM has tackled the pandemic overall till date, from the start to date, and what have been some of the learning in terms of dealing with this.
Yes, to start with, let me tell you, the pandemic or whatever the COVID-19 pandemic which has happened across the world, it was as new to us as well, which as new it is to you as well. So we were not even trained for that. When I appeared for this exam and when I selected as Assistant Commissioner, I was never aware that I have to deal with such kind of pandemic as well, because I'm basically an engineer. And our job is mostly about the roads and footpaths and gardens and open spaces, and very less part of healthcare facility, that too with the social angle which we were involved. But this was the very different experience. Let it be handling the lockdown, or let it be handling the positive patient, let it be testing things and how to behave with the available limited kind of resources. That was a really challenging type. I still remember when I came back in Mumbai from Goa, when that was Holi was there, and it was declared that Holi will not be played. And I was like, what nonsense is this? ये तो Chinese virus है, Chinese virus थोड़ी टिकता है करके ऐसे. So this is all exaggerated thing which is happening. But actually when that lockdown happened, so it was more about managing the lockdown and managing the public, because it was first, I think in the last one entire century, we have never seen Mumbai, standstill Mumbai, and how to manage and how to deliver groceries and everything at their home. That was one challenge to start with. to close all the shops and to arrange the deliveries and all. And second was the health aspect. Nobody has clue, including the experts and including the doctors and all, how to deal with this, whether to test more, whether to test less, whether to isolate, whether to isolate high risk contacts, or whether to isolate only positive people. I still remember initially when we started isolating, we realized that when we isolate all high risk contacts in one place, we are actually asking them to infect each other, because we are isolating all high risk contacts in one hall only. And then we realize that if one patient of the high risk contact is positive, the all will be positive. I still remember the cost of the test was 4,500, and the test result used to come after 3 to 4 days. So you can imagine how to keep people into institutional quarantine and ask them for wait. Many people died in between. They tested. The first case in Dharavi appeared on 1st April. And before that, the Dilshad Sheikh, the person, we tested him first. It was means on Thursday we tested. After 3 days, the test result came as suspected positive. We again tested him. After 3 days, second result came that he is positive. And till that time, he died. There were many people who were actually coming for the breathlessness and complaints of breathlessness on everything. And we were asking them to whether you are tested or not. Means even normal patients were not admitted. So this all things initially happened was totally, means everybody was, entire system was new to that. But somehow with the help of center, with the help of state, with the help of experts or doctors, everybody who is including in the panel who are there, including Dr. Gautam Bhansali as well. So they all guided us how to isolate people, how to set up institutional quarantine, how to arrange fewer camps. Then we realized that let's arrange fewer camps first. So I think I should share something about Dharavi, how we have, means I just like to share about the Dharavi first, that how we have gone ahead. And that was the actually model which was followed everywhere across then other slums as well. When the first case appeared in Dharavi on 1st April, so that was a death case, means the corona entered in Dharavi with a death, we can say. The first thing we realized that there are many people who are rushing out to hospital complaining of breathlessness and all, even before they are tested. And it was practically not possible to test each and every person. That too, in slums, most of the people depend on community toilets. So most of them were getting infected because they are using the same toilets. Means as Mr. Arunji, you must be aware how the situation in slums are. The one toilet is used by another 500 people. And if imagine the infected person who is using that community toilet, and that is used by another 499 people. So you can imagine how fast it must be spreading. And there is no logic of high risk contacts. What is high risk contacts and how to identify them? So what we did in slums is actually we started arranging fewer camps in the area. So what has happened, those people suffering from fever got prioritized. They came forward, we tested them first and we isolated them first. Similarly, we start screening the entire slums and we started checking the oxygen levels of the person as well as a temperature of each and every person. And we started isolating these people who were actually the suspects. And we started institutionally quarantining them. Again, the institutional quarantine was another challenge, to give facility, 3-course meal, like morning breakfast, afternoon meal and evening dinner. So everything was provided. Then we started providing doctors, nurses, ward boys at institutional quarantine. We started supplying oxygen concentrator in the area, because we realized that even in institutional quarantine, many people were actually dying or actually needing for the oxygenated bed, and there was no bed as such. Then again, we acquire few hospitals as well. Means that was really a game changer, that we acquired few private hospital in BMC's kitty and we totally converted into DCHC or DCH, dedicated COVID hospital or dedicated COVID health center. And then again, oxygen supply was given to them. So these were all, means what I was trying to say is it was all trial and error. There was no reference book for such kind of pandemic. And as you were learning, we were also learning. We're learning from the mistake every day. Every day we're realizing that this is what is happening is wrong. Again, we are correcting next day, we are doing that. And this is how. And then issue of migrant labor, that was another challenge. People in places like slums, especially in Dharavi, where a family of 10 people stays in a room of 10 feet by 15 feet, and they all depend on the street food or community. Most of the families don't even have a kitchen in their houses. They all depends on street food, as well as depend on community toilet. Similarly, most of them were migrant workers, and they are all hand to mouth. If they earn for the whole day, then only they can have a food in the evening. And another said plan was to distribute food across Mumbai, especially to the slum people. I still remember 200 were actually staying on tracks, migrant laborers, and they were calling, and I got a call from somewhere that 200 people are stranded labor, and they are not having food since 2-3 days. We actually started them from searching them from Dadar to Mahim on railway tracks, and we find they have made their hutments a camp type situation, and they all were waiting for the waiting for their food and all. So this was another challenge that we distributed. Means I still remember in Dharavi, we used to distribute 19,000 food packets for lunch and 19,000 food packets for dinner. So it similarly to talk to hospitals, bed management, setting up the war room. It was all very, very different kind of experience, and very challenging and very learning, we can say.
Thank you, Mr. Dighavkar. I have known you since you were Assistant Commissioner of MBOD, and we are familiar with the situation, especially in slum areas. I have a follow-up question on the question of resources, basically the human resources. I mean, today India has 29 health workers per 10,000 people, while we need 60 such professionals per 10,000 population. This is as per the WHO norms. If we look at the overall vacancy of the MCGM medical personnel over the years, while it was 27% in 2015, it was 47% in 2019. True. These were vacant positions in MCGM. During the pandemic, I remember the Chief Minister requested retired health personnel to resume work to manage the health crisis. Now, what would be your recommendations to reduce the gap between the required and the available medical personnel?
See, what I personally believe, or what I've experienced in last 1 year, it cannot be only government's responsibility now. We have to engage private personnel. And if I tell you about the Dharavi experience, it was more about the NGOs who come forward and who actually help. And the community participation has become a great key for any means government scheme to be successful. We cannot have that ivory tower approach anymore, that the government is actually doing on their own anything, and there is no clue what is happening actually on the ground. And you must have experienced the similar thing when you were working with Apnalaya and all in Govandi, that government has his own way of dealing the things, and they are nowhere connected with the ground people. So we need NGOs, we need private participation in such situations. So I believe instead of simply employing people in the corporation and simply ask them to do, so we should focus more on community participation. Because over the last 3-4 years, what we realize that there are many people who actually want to help the society. They actually want to work with the community and do something. We need to tap such potential. There are many such good NGOs, many such. I will not name anyone, because naming anyone may be hurting the other one. So, but what I realize is there are many hands who actually want to work, not with the money only, but with the noble work. We have seen this in Swachh Bharat Abhiyan. Many beach warriors are coming forward. They actually go on beaches, Mithi River, they actually clean with their hands. Although they are working somewhere in corporate field and all. So similarly in health also, we need to tap such potential. We actually look forward for the public-private partnership. We actually look forward for the genuine people who will get in this community. Because what I realize in slums especially, that the slum people are means they are not connected with the government. They don't connect well with the government authorities because of their own problems of legality and illegality, because they have their own, they are dealing with unauthorized water connection, they are dealing with, there is no sewer line in the area and they are just throwing their sewage in any river or creek. Or similarly, there is they have their own 2-3 story hutment which is not even legal. So they are not well versed with the government authority. They means the government of authority for them is always someone who actually want to remove them. So we need actually people in between, a mediator, a good NGOs who will actually come forward and get these things done. So instead of, I am not supporter of this thing that people should, means government should employ more people to do it. But in fact, government should take help of these private NGOs and private corporates to deal with this kind of situations, which I personally believe.
Thank you. Thank you, Dighavkar sir. I think this is something worth taking note of, that a city cannot be resilient without community participation and without a responsive government. And there is a need to bring the two together. That point is well taken. And I think that's one way of developing any kind of endurance or resilience to deal with anything of this kind, that what we have experienced in the last 13 months. Let me now turn to Dr. Swapnil Parikh, our final panelist of the day. Dr. Parikh, what would be your major takeaways from the experience of handling the pandemic so far? This pandemic has shown us that countries like the USA or France or Italy suffered so severely because they have a poor primary healthcare system, whereas countries like Thailand did very well because of their sound primary healthcare system. The similar trend can be seen even in India, among our states with better primary healthcare have managed the pandemic better. How can Mumbai upgrade and empower local clinic facilities for preventive and primary care? Dr. Parikh.
Good morning, all. Of course, primary healthcare is important, but I think we need to differentiate between correlation and causation. I don't think we can say based on data that the differences in the primary healthcare apparatus were the primary determinant of outcomes in these countries. World over, the primary determinant of outcome is age-specific exposure, the age distribution of the population.
Sorry, we couldn't hear you. Dr. Parikh, we are unable to hear you.
Are you able to hear me now? So I think the primary determinant of outcomes during the pandemic is not is the age distribution of the population in the country and the age-specific exposure rates. So if we look at a country like India, for example, where 40% of the population is below 18 years of age, only 6% of the population is above 65. That's the population that's really at risk of COVID-19. And the average age of our population is 26. I think that's the main reason why India has had at least overall lower mortalities. We would need to see what the infection fatality rates were in those age-specific categories. So when you compare the whole population of India versus the whole population of another country without looking at the age distribution and age-specific outcomes, it can give you a false impression of what's happening. The second thing is we also have to realize that India doesn't have good codification of mortalities. We're still just codifying mortalities from a couple of years ago. So without accurate mortality data, it becomes very difficult to pass out what factors have resulted in better outcomes in India versus other countries. Or indeed, even if we have had better outcomes, I think we have done a little better than people thought we would do. But have we done better than we should have done, considering our population is young? That's a difficult question to answer without accurate mortality data. So what are some of the things that we can do? Of course, we have to improve primary healthcare delivery, not just for COVID-19, but for everything. It's very important. I think you also need to realize that India's still not done with the pandemic. As
Seems
one
to
of
be
the other
some connectivity issue, Dr. Parikh. Intermittent.
apologies. Are you able to hear me now?
Yes.
Am I coming through okay now?
Yes, you're audible.
Apologies for the connect. Apologies for the connectivity issues. So I think we need to recognize that India may still be relatively early in the pandemic. As was pointed out earlier, some countries were hit earlier in the pandemic, some countries were hit later. So if we compare at the same time point, we may have a very different picture. We also need to understand that the distribution of pre-existing high-risk conditions, of course, as a factor of age, is very different in India. So it's very difficult to compare pictures overall and then attribute one specific action for those. And now when we look at data currently, I think one thing we need to clarify, there is no evidence whatsoever that a higher percentage of cases are asymptomatic. That claim has been made repeatedly throughout the pandemic in multiple countries with disastrous outcomes. What we are seeing right now is we are seeing a massive increase in transmission. Mortalities do not occur immediately. People infected today will not die today. They will die anywhere from 2 to 8 weeks later. So the infections that are occurring today are going to result in mortalities later. They're going to result in hospitalizations later. So when you look at 40,000 confirmed, 50,000 confirmed cases, you have to recognize we're only catching 10% of those cases. There are likely, 10 times as many infections per day in India. And all of the people who are infected today are going to have hospitalizations and severe outcomes later. A certain percentage of them will have hospitalizations and severe outcomes later. So if we look at today's infections and today's deaths, we need to recognize that the deaths that we're looking at today are actually due to infections that occurred earlier. So we shouldn't comment yet on how India is going to do in this wave. We drastically need to reduce transmission. When we talk about how we're going to respond, what can we do to respond to future pandemics, let's remember that we're still not fully responding to this one. I mean, there seems to be some amount of policy paralysis. I guess everyone is a little fatigued. And we urgently need to solve this problem and recognize that the tools that we build out now, whatever investment we make now, for example, in molecular diagnostics, in rapid point of care testing, point of need testing, the investments in those will help us in future pandemics. A lot of the molecular diagnostics we're building out for COVID-19 can be repurposed for tuberculosis. Airborne infection prevention can be repurposed for tuberculosis. A renewed focus on ventilation and indoor air quality will reduce COVID-19 right now, but will also help keep our hospitals and our community safe in the future against other pandemics, against tuberculosis. So whatever investments we make in scaling out in primary healthcare now will serve us well later. But keep in mind that we have collectively failed to scale out public health over the last several decades. So scaling it out in a few short months during a pandemic is a little more hopeful than we'd like. It's not easy.
Thank you, Dr. Parikh. I think two important points with us. One is state and data is to comment on that in terms of where we are today. Both in terms of what
Arun, we cannot hear you. I think you're having an issue with your internet. Uh, I will maybe take over from Arun till he joins back. Thank you, Dr. Parikh, for bringing out some very important points, and most importantly, as you rightly said, that we haven't yet finished with dealing with the first pandemic or the first wave, and we're talking about now the second wave, and now we're going to the third, in the sense maybe going to the third, and we shouldn't be at the moment talking about future pandemics. Since Arun is back, Arun, please carry on with your next question. Thank you.
Sorry about the connectivity. I think I was asking if it's possible for our other members of the panel to comment on the 2 points Dr. Parikh made. One was about the need for better and more granular data, and the other point was about the state of public healthcare system. And related to that is the question that I wanted to ask: does Mumbai is there a minimum health service benchmark? Should there be a minimum benchmark, and does Mumbai have it as a metropolitan city? So anyone, Dr. Bhansali, Dr. Ansari, Dighavkar sir, anybody, would you like to comment on these 2 points?
Yeah, Arun, Dr. Bhansali here. Yeah. So as far as Mumbai is concerned, definitely we are much better off as far as that primary health center or some sort of that initial clinic or first clinic you said, that concern is there. Definitely after COVID, the things have much improved. You can see in the difference in the budget also, not only the state government budget, in fact, the central government budget also, they have improved it or they have increased budget for the health infrastructure. That COVID definitely taught us a lot, that we were very poor in the, as far as infrastructure is concerned. Although we have good doctors, good nurses, good ward boy, all staff is good. Or you can see the difference between the BMC staff, the way they were worked in the COVID, that was totally different, totally different. You have seen the change of the image in the BMC or police personnel also. So the criteria for that primary healthcare center, see, if we see that the vaccination program, why vaccination program is not speed up what we have thought. Our planning is to do per day 1 lakh vaccination in Mumbai, but we are doing like 40,000 or 50,000 short of, because government of India is saying that you can do vaccination with ICU backup setup only. You can't go with ambulance, or you can't do vaccination door to door sort of. You have to do vaccination where you have ICU backup only. So we are still having some lacuna in our healthcare centers or in our that primary center sort of. Although we have good private hospital, we have very good jumbo facilities for COVID, but overall scenario, if you have seen for the health, just forget about the COVID, other way like tuberculosis, like cardiac failure, we don't have 1 point contact where suppose somebody suffer from cardiac arrest or something, some other problem like in the middle of night or cardiac failure, we don't know where to go. although we know that Mumbai is a financial capital of this country, we should have at least one point contact where one can press, like in US 911, sort of we should have that facility. We can reach out immediately for the medical help, this kind of primary, like first aid sort of help, which is still we are lacking. And I feel after this COVID, we will go for this kind of facilities.
Thank you. Thank you, Dr. Bhansali. Anybody else? Dr. Ansari, would you like to comment on?
Yeah, no, I think
discussing?
very pertinent points were raised by Dr. Parikh. I think I would like to, middle it rather than saying that, yes, we are into a very, very, negative state. At the same time, I completely understand that our healthcare budget allocation and utilization has to be very closely monitored. I think we must understand that the divide has been there for a long time. So it's not that we are going to rectify it immediately. But this to have a healthcare, accountability, where every person should have a universal access to health and has certain attributes, means that easy access to your healthcare and getting the same kind of care in any kind of a setting is very important. And lastly, I think we need to keep on asking ourselves how many beds we have increased. I don't see any great number of beds in the public care domain to have been incorporated in the past 10 years. In the past 1 decade, probably we have not even added more than 1,500 critical care beds, which is something which we need to ask. So the state and the center needs to look together and keep on having very clear, as you rightly pointed out, 47% of healthcare kind of workers' positions have been lying vacant. And this is a very clear-cut eye-opener, I think, and that is only because of poor healthcare budgetary allocations. But as Mr. Dighavkar also very clearly said that it is also going to come from the public and the government partnerships. Everybody has to, look at health as a very important, requirement, and we need to have universal health capability for all. And there should be some benchmarking that every person, wherever he is, should be, having access to.
Thank you. If I may add to what Dr. Ansari has said, if we look at the last 3 years of MCGM capital health expenditure, in the last 3 years, about 58% has remained unspent, the capital health. Now, how does one make sense of this underutilization of the budget? One question is that perhaps the overall budget allocation should be better. More money should be allocated for health. The second situation, last year, 50% of health. Mr. Dighavkar, anybody else would like to comment, to react today?
Yes, Mr. Arunji, I really agree with that. And as I told you earlier also, a city like Mumbai or the corporation like MCGM, Municipal Corporation of Greater Mumbai, the budget was never the problem and is never a problem or will never be a problem, considering the amount of population we have. The problem is how to deal with multiple kind of problems at the same time we are dealing with. So what we need is, importantly, I again repeat that, like I told a few minutes back, that it is about community participation and it is about responding, people's response to the situation. Means we are, no doubt, we are doing our bit, we are allotting the budget, we are not able to spend because we need more hands to deal with that. It's not about, like, it is simpler. Means I always give example of the Swachh Bharat Abhiyan. The Swachh Bharat Abhiyan or was right from Gandhiji's time, that Mahatma Gandhi used to tell ki we should clean our but when we entered into this mission mode, since 2000 October 2014. Many private players came forward and they started doing, everyone started doing their bit. The businessmen started doing bit of doing businesses in waste management. Similarly, the social workers started doing their bit in their arena, or the NGO started doing their bit. Similarly, we need such kind of warriors in health as well, that the private participation and the community participation. We need to bridge that gap between the government who intend to spend, the government who intend to run the schemes, and a mediator who is actually bringing the beneficiaries or the eligible beneficiaries or the right people to the government. So what we are missing right now in the system is this bridge and this gap, which needs to be filled. I don't think so every person in Mumbai has enough money who can help the other person in the city. Means I have seen lot of disparity. I have joined first in Govandi in Amist ward as Assistant Commissioner, and my next ward was Kulaba, the Nariman Point area. Means it was simply dirty to Asman for me when I visualize the difference between the social strata and all. But on the contrary, in Kulaba and Nariman Point, there are many good people who actually want to do something for them. There was no, means as such, they don't want these people to be here or not. So we need to bridge such gap with the help of the private players or the right intent people, the right NGOs and right agencies who actually get us to this thing. So it is not about budget. It is all about rightly spending and the right approach. So we should work on right approach as well along with the budget only.
Thank you, Dr. Dighavkar. Dr. Bhansali, I have my next question is for you. I mean, given what we are discussing at this point in time, Mumbai is faced with widespread inequalities in terms of accessibility of healthcare services. Is there perhaps a need to prioritize and integrate healthcare into the urban development agenda?
I feel we should integrate with the urbanized, and that private, as Dr. Mr. Kiran Dighavkar has rightly said, that we should invite private player, and BMC is already doing so. Like there are few hospital of municipal corporation which is not utilized properly, which is not functioning. They are already giving it on some lead basis to the private player, and there are some reservation in that hospitals for that for the community and all the things. I feel personally we should invite more private and public partnership sort of, and that model will be successful in city like Mumbai for the especially primary as well as community health center sort of.
There is a question which is open for everyone. It's about basically strategies for better outreach. Strategies are core to epidemic control, while generalized lockdowns come at a very high cost. How can an outreach-based strategy be made more effective with a greater focus on community participation? What are the steps to achieve community empowerment, for instance? If I give one example of self-help groups in India, there are about 70 million, 7 crores self-help group workers. Could we think of engaging them maybe in awareness building, maybe in improving health-seeking behavior of the community in general, while the government and the corporates play their part? Is it of improving the outreach in terms of combating the pandemic? Anybody? This is not specific to any individual. Anyone could respond to this. How can we improve the outreach?
if I may take that question, it's a very open-ended question, a thought-provoking one. Coming together, we all need to sit together. We have done a similar act. If you look at what exactly we did in a lot of those jumbo centers, where there were kind of mentors designated for those jumbo centers from the public area, from the private hospitals, who went over there. A lot of healthcare workers who were working were kind of, I would not use it's a harsh word, but saying that they were probably directionless in the beginning to see the kind of swarm of patients who were coming. But then with the experience of those people who were managing those sick individuals, there was a sense which started to prevail. People started looking at, triaging, separating out the sick ones at one place, the less sicker ones at another place, creating protocols together with their limited resource at hand. So I remember there were no CT scan facilities at the Jumbo Center, and there we decided not everybody needs a CT scan. There could be a portable CT scan, or we can try to shift them in a planned manner at a place close by, get all the CT scans for those red flag ones, get them back, triage them, and move them as a spoke and hub kind of a center where they can go to the nearest dedicated COVID hospital. So I think one of the most important thing is we need to strengthen digital platforms now. And we have good technological support to do that, where we can have experts looking at those selected, red flag patients and guiding their further movement. Number one. Number two, training of a lot of BMC and the other healthcare workers to have those, cutting edge knowledge, very simply distilled and given over to them as a small, kind of ECMEs, where they are probably given the more important kind of information to practice. And lastly, I think we need to look at some kind of incentivization of those people who are really frontline workers, who are spending their time, who should be given advantage so that they can take care of their own families more effectively, staying away from them. At the same time, for the hard duty in the front, they know that they are being respected in whichever way. So these are the few thoughts that I have, but most importantly is to come together. The public and the private should come together, devise certain kind of workshops which can extend these training and have some digital platforms to really bridge the gap between the care in a very remote area to the care in one of the super specialized hospitals.
Thank you. Dr. Parikh?
Yes, yes. So
Yes,
just
please.
I wanted to add a couple of points to both the last two questions. So about inequalities in healthcare, we need to recognize that healthcare isn't just about hospitals and clinics, right? It's about everything that's around healthcare as well. So when you start talking about health outcomes, public sanitation, access to clean drinking water, access to food, shelter, making sure that diseases, tropical diseases like tuberculosis, malaria, dengue aren't spreading in the community. Overcrowding isn't occurring, that there's some emphasis on indoor air quality, both in terms of infectious diseases and indoor pollution in those communities. Education, especially girl child education, the education of young women. We have to focus on all these factors if we want to fix inequality in healthcare. You have to build the foundation up. Addressing access in healthcare will only occur when all the systems that lead to good health outcomes have equitable access. So I think that's very important. We have to build for the future, and we have to do all of those things. Uh, you know, we still in our country, even despite healthcare advancement, is still ravaged by diarrheal illnesses, especially in the under 5 population. This has largely been fixed in many countries just with clean water, access to good hygiene and sanitation and food. So we need to do those things also, and of course, build out more healthcare facilities that people can access. To get community participation, I think two of the things that we really urgently need to do now and then for the future. So two of the things we need to urgently do now is more home-based testing. So we need to empower people. There's this notion in the powers that be that if you allow people to test themselves, uh, that is bad. Somehow there'll be a lot of false negatives, or people won't report their test results. Just give people the power to know their infection status in their own homes. Even if you catch 50% of those infections, you're going to break transmission chains. We need to decentralize this power. We need to change our approach to testing. Give people the power to know their infection status today. It's very easy to do a home test. The second is community-based vaccinations. Now we're expanding out vaccinations to include everyone over 45. Think about how much virus there is in Mumbai right now in circulation. And you're suddenly going to have a huge influx of people into vaccination centers. You're going to keep them there for 30 minutes to observe them. I would think in that 30 minutes, the risk of acquiring COVID-19 far outweighs the extremely low risk. It's a real risk, but it's an extremely low risk of severe adverse events following immunization. So we need to balance and weigh these things. Of course, we need to reduce the risk at the vaccination sites, but we should also open vaccination in the community setting and even possibly at home for senior citizens and individuals who have high risk conditions. There's just something so tragic about someone getting infected and dying of COVID when they came to get vaccinated. To me, that just sounds so tragic. All COVID deaths are tragic, but that one is so particularly tragic. And if we want to build for the future, the one thing that we know improves access and community participation is having community-based healthcare workers. People don't respond well or as well to healthcare workers from outside their communities. So if you see communities that have poor participation in healthcare, poor healthcare access, the best thing you can do for those communities to empower healthcare resources, ASHA workers, auxiliary health workers, even doctors from those communities, people who belong to those communities, people who speak that language, and people who understand that population. That will massively increase community participation. Technology is great, but we also need to remember that technology can actually increase inequality in access. So, for example, when we moved all vaccinations to COVID, what happened? The exact target groups for vaccination, that's the elderly, they can't access technology as well. They were so dependent on their kids being able to register them for vaccinations. What if someone is unable? Then we had to fix that, right? We had to go back to the old way of registering things. So we first always need to start with building out the base, and technology and more high-tech things are always things that augment and that facilitate. They are not the solutions to inequality or community participation.
Dr. Arun,
Yeah.
yeah,
Yes.
to add on this,
Yes, Dr. Bhansali.
see the Mumbai infrastructure and Mumbai, that things are totally different. Mumbai, there's always all people or maximum patients are connected with their own doctor. Like you say, everybody saying this is my family doctor or this is my doctor. And the second thing is that Mumbai is a bit different because people are having more faith in a private hospital rather than public hospital. So what I still remember one thing, that our present municipal commissioner, Mr. Iqbal Singh Chahal, called me one day, that he told me ki we made our Jammu facility like anything. We are given all the facility, but that people don't want to go to Jammu facility at all. What is the reason behind that? Next day, me and Mr. Narvekar, who is heading the disaster management, we took round to all the Jammu facility, right from this NACI, Worli, BKC, NESCO, Mulund, this everywhere. And we have seen the Jumbo facility. I can tell you, Mr. Arun, that Jumbo facility is far better than all private hospitals. The way they were doing testing, the way they were taking care of their patients, that was much better than the private hospital in Mumbai. But people still don't want to go to Jumbo facility. We find out the 2 or 3 reasons. One biggest reason was the perception. The perception was that doctor may not be good, or that we will not get proper treatment, or the Jumbo facility is only like a quarantine center or isolation center sort of. So what we did, as Dr. Ansari was saying, we called all big private hospital, and we created like a mentorship sort of program. Like Bombay Hospital and Bridge Hospital, they will take over this NSA, just like a mentorship. We were coordinated with that NSCI Worli, that dome facility. We were totally coordinated with that doctors from there. And I advise Municipal Commissioner Saab that we should have two unit of medical college hospital doctors in the jumbo facility. They are very good doctor from that medical college doctors, and they will coordinate with the private hospital doctors, and we will just go in the public, and we will say that all big private hospital doctors like Bombay Hospital, basically they will look after the NSA Valley, Leelavati, and this Hinduja, they will look after the BKC Jumbo, Nanavati Hospital, Kokilaban, they will look after Desco. That sort of things we created, and just after that, in a couple of days only, the you can say that occupation that in that jumbo facility, initially it was only 40-50% done. Then after that mentorship from the private hospital, that gone up to 80 to 90%. So the major thing in Mumbai is that we need to, as Divya was saying properly, that we need to bridge and we need to come together to create these facilities, or we have to come as a public and private partnership. That is the only way we can sort out this kind of health facilities and health problems.
Thank you, Dr. Bhansali. Can we take a minute to reflect on what exactly it means to be a pandemic resilient? If the city has to be resilient to engage or to deal with something of this kind, we cannot approach this issue only with the medical lens. Dr. Parikh was also raising that perhaps there is a need to look at various aspects and how as a collective, how as a city we can deal with it better. And of course, one issue is to look at the medical part of it and see where improvements are needed. But the other part, what we are repeatedly talking about is what about community participation? What about dispelling the myth or misconception of people, for instance? What about the communication strategy about the pandemic, about the infection, about the vaccination, for instance? Is there any learning in terms of reaching out to people to improve communications, to improve their awareness about the infection and the steps that are being taken to deal with the infection? Dr. Bhansali, would you like to respond to that?
Sorry, I couldn't hear your questions. There are some network issues.
What I was asking is that, is there a need to reflect on the non-medical aspect of this entire effort to emerge as a resilient city? Of course, medical is right at the center, the medical reason, the health, the facility, the there's also a non-medical, if you wish, aspect to it. One is about communication, misconception about the disease or infection, or as you're rightly pointing out, people's fear about visiting jumbo hospital facility, for instance, or misconception about vaccination that we sometimes encounter in different areas of the city. So one part is looking at communications. Could we have done better? What should we do from now
Yes.
on? That's
yeah,
the
Dr.
first
Arun
question. I'll come back to that later. Yes, Dr. Ansari.
Yeah. So the communication is really definitely very, very important for that. But the problem is that maximum doctors are engaged with the COVID and some other work also. So I feel for that we need some sort of good NGOs who can help us in that. So like a vaccination program, we are definitely lacking behind in vaccination, especially in the Mumbai. Our target is 1 lakh vaccine per day. See, initially, government of India was not ready to start vaccination in the private hospital. So we fought with the government of India with the help of the government of Maharashtra and municipal commissioner, and finally they allowed private hospital, private centers for vaccination. And we were thinking we will vaccinate per day. Each private hospital will vaccinate per day minimum 1,000 to 2,000 people. Then we demanded why not vaccination centers should be open for 24/7? Why only morning 9 to 6 and 6 o'clock server will shut and like that only. Then they accepted that demand also. They said, okay, go ahead for 24/7, or even you can open on Sunday. In spite of that, it's very sorry to say that the private hospitals are not doing much vaccination. Like many hospitals are doing only 100 per day, or maximum one or two hospitals are doing more, approximately 1,000 vaccination per day. But if you want, we can do more than that. For that, we already requested so many NGOs, they should come forward. They will go and talk to the people that there's no vaccination hesitancy, or they should go to housing societies. They build confidence in the all the people that vaccination program is good, or they can bring to the hospital or centers, rather than some jumbo hospital where you can see the lot of crowd. This is not the matter of 250 rupees or these things. But I feel we now we should involve good NGOs who can reach to the public, who can educate public regarding vaccination, regarding the disease, when to admit, when not to admit. Sometimes many patients, yesterday only I got so many phone calls, we need to admit our patient in Bombay hospital, we need to admit in Rich Candy hospital. When I asked them what are the symptoms, they said sir no symptom, symptom to nahi hai, but हमको admit करना है, एज है, बाद में बेड मिलेगा नहीं मिलेगा. Okay, I said कि yes, आप patient भेजो. Then they said कि no sir, they are okay, patient is okay, but we are just checking कि bed available है कि नहीं है. So that sort of panic is there in the city when number of cases are increasing. In that manner, I feel personally the private NGOs will definitely will be a better help for us. Like we include teachers who are not going to school for the long time because schools are set and all that things. So we involved municipal corporation, involved teachers for that COVID help and all the things. So same sort of we should call good NGOs for our help, for vaccination, for awareness about the COVID, when to admit, when not to admit. Today we have 13,491 bed in Mumbai. Out of that, 3,000 beds are in private hospital, but each and everybody wants private hospital, respect of whatever rates are there or not. So we cannot accommodate all patients in a private hospital. We want the needy patients should come to hospital. In that manner, I feel private or some NGOs can help us a lot, and communication is the biggest weapon in this.
Thank you, Dr. Bhansali. As we are coming to a close, I need you to take a minute and share with us, as your concluding remarks, what the learning has been and how differently are we going to now deal with this problem. One of the concerns which is coming repeatedly in the chat box or question that people want to know is that is it a possibility to have some kind of social audit of how we have dealt with this issue, where we invite people's opinion, where people share their concerns, and is that a possibility? Basically, how can we involve people to create an atmosphere where everyone has equal amount of confidence in the measures that we are taking to ensure that the city is indeed resilient? Please take a minute, each one of you, in whatever order you want to go. Maybe Dighavkar sir, अगर आप शुरू करना चाहते हैं तो maybe you can go first.
As I like to answer the title, The Resilient Mumbai, is our city pandemic ready? I said ki yes, Mumbai is resilient for this pandemic, and we are dealing in a efficient way. Let me tell you one thing. Many people have this question in mind that why in Mumbai, why in Maharashtra, why here only cases are rising. Let me tell you one thing very clearly, that where the health system in India is robust and comparatively better, you are getting more cases in such areas. So it is not about whether spread is there or not. It is about whether we are able to find out the spread or not. So I think I very proudly said ki yes, my city has identified 5,000 plus cases yesterday because we approach them and we find out. I cannot name the other cities. across India, but there are many such cities, such states that you need to struggle a lot to find a testing center in that particular area, and you need a prescription, you need a receipt to test yourself. There are many more cities or states like this, but I proudly said that my Mumbai is approaching to people, they are testing, we are enabling them, and we are very transparent about our data and all. So we are resilient for that, and we are doing that way. Second important thing is, as you said, many more appreciation will come for BMC and the system after the social audit, because the way we have dealt with the migrant population, the way we, specifically Mumbai I'm talking about, the way we have handled about the food packets and the ration packets, and the way corporates came forward and helped them. In Dharavi, I still remember I used to get a call from many celebrities, corporates, and many local representatives that we want to help in Dharavi. We want to give this kind of ration packets to people, and we have distributed 25,000 grocery packets in the area. These 25,000 families got the groceries of 1 month in that particular area, and food is unlimited. Many people distributed on their own, many people distributed ventilators and all. So if social audit has to be there, and I'm very confident that BMC will come out with flying colors in that audit as well. So definitely we are ready for everything now.
Wonderful, wonderful, Dighavkar sir. It's quite reassuring. Dr. Ansari, your thoughts?
So I think we need to said very well, and we are coming to the conclusion that yes, we are definitely ready for the pandemic. Yes, at the same time, it's not a matter of overconfidence, but rather a very graded approach and a very clear understanding of our limitations and how we can scale up ourselves. And there is no point, there is no place of panic in this kind of a situation. We need to really have more self-confidence, self-reassurance, at the same time transparency of the reality, and knowing what are the facts, where do we stand. And the most important thing which I would emphasize over here is an underutilization of our vaccination potential. I think we are the world capable. If you look at the number of vaccine doses which India is capable of, I think we can take care of our entire population in a phased manner. I think one suggestion which has come recently was that let's empower, or the government should empower, all pediatricians in Mumbai city itself. They have a cold chain with them to give vaccinations to those selected people who register themselves on the COVID app and come to them, and they are capable of providing BLS and ACLS care. So a trained pediatrician who have been vaccinating for ages, all pediatric populations should be empowered to give vaccine to adults above the age of 45. There will be a lot of decongestion. People lakh vaccinations per day, and within probably 90 to 100 days, we should be able to have a good human barricade of people who have been vaccinated without having, as Swapnil said, that going through an infection while going for a vaccination center and getting crowded. So I think that is something which should be taken. It has already been suggested to the government. I think this should be a very important suggestion to take forward.
Shall I go next?
Thank you. Sorry.
Sorry, we can't hear you.
Mr. Bhansali, can you give your inputs, please?
Yes. Sir, one thing I can tell you that Mumbai is the first city in the world who allowed testing for each and everybody in Mumbai, or whoever wants to go for testing, without doctor's prescription in the month of July only. That time you were needed doctor's prescription for the testing, but Mumbai is the testing. We should not fall into number game at all, that whatever number comes, 5,000 or 6,000 or 10,000, doesn't matter. Mumbai is totally prepared for the worst come worst things. We have enough bed capacity in the government setup, in jumbo setup, and in private hospital also. We have maximum oxygenated bed in this COVID, in this disease. We need mainly oxygenated bed. So we have many oxygenated bed in our hospital. More than 10,000 oxygenated beds are there. Treatment wise, all treatments are available, all medications are available. There is no shortage of medicines, no shortage of doctor acumen, no shortage of healthcare personnel at all. So I urge public or patients to not to be panic at all in this situation. Whatever number is there, you should not be worried at all. Second thing I would like to say, we want help of NGOs. With the help of them, we should go to housing societies. See, we have done more than 5 crore vaccination in this country. And out of 5 crore, not a single patient collapsed because of vaccination. So why not government of India allow us to go door to door for the vaccination? We have enough ambulances, we have good skilled staff, pediatrician, doctors, everything. So they should allow us for the vaccination. There should be surgical strike, or you can say mass vaccination program in our country. And one thing I can assure you, Mumbai is totally gear up, whatever number will comes. And one thing again I can assure you, Mumbai is safest metropolitan in the world, and Mumbai will be safest metropolitan in the world. Thank you.
Thank you, Dr. Bhansali. Mumbai is the safest metropolis that we have. Dr. Swapnil Parikh, please, your thoughts.
So first, just some broader thoughts, and then I'll respond specifically. Biosecurity is a national security issue. We're seeing during this pandemic that a virus, a novel coronavirus or a pandemic virus, can be as much of a threat, more of a threat than other national security issues like terrorism and neighboring countries that we have issues with. We need to be as ready for pandemics and for disasters in general as we ready ourselves for other national security issues. Another thing that we have learned in this pandemic is, if you want to be a great country, you have to make things. We have to be able to manufacture the things we need during a moment of national crisis in our own country. So ventilators, molecular diagnostics, medicines, protective gear. And it's good that vaccines, the raw materials for vaccines, the manufacturing equipment for vaccines, and it's good in a national crisis, Indian manufacturing has been able to respond. We need to build out those capacities. We need to integrate with the rest of the world, but we also need to make sure that in a moment when there is demand across the world, we are able to meet that domestically. We've been talking about inequality a lot and inequity in access. We really need to focus on equity in healthcare access in all the peripheral areas, because we're seeing that pandemics can really expose inequities in our societies, and the privileged few can't be safe while the less fortunate many are unsafe. We are all as safe or unsafe as the weakest members of our society. Disease surveillance is so important. So being resilient is one thing, but there's something to be said to detect an outbreak really early and stamp it out, so that people don't have to suffer to begin with, so that people don't have to be resilient. We should have the tools for early identification and response to outbreaks. I can quite happily tell you that in facilitated by MCGM at Kasturba Hospital, we are working specifically on that: genomic epidemiology and outbreak preparedness and response. So we're building out those capacities in close coordination with MCGM, and hopefully we'll be better prepared this time, and we'll be able to respond this time and better prepared the next time. What are some of the other things we need to do? I think we're seeing right now that data integrity is one of the key things. So we need to make sure that we have good data so that we can pass out what are the areas we need to improve, what are the areas we need to focus on. We're seeing that point of care and point of need diagnostics are so important. Vaccines, we're talking about distribution, but let's be realistic. Our manufacturing capacity isn't where we thought it would be, and it's good to say let's do 5-10 million vaccinations per day, but just think about that. If you get to 5 to 10 million vaccinations per day, you're talking about at least 150 million doses manufactured per month. And as you scale, you need to scale your manufacture to make sure you don't hit bottlenecks. It takes time to scale manufacturing while making sure that the quality is also there. So we need to scale manufacturing. We need to ensure that our manufacturers have access to raw materials and equipment. There are some export controls being put in the West against these exports of raw materials. And we need to desperately accelerate existing vaccines. Like, for example, Covovax, the Novavax candidate, has now been shown highly efficacious in phase 3 trials across the world. So we desperately need to scale out, start distributing vaccines like this very, very quickly. There's a huge gap in genomic epidemiology in our country. So we massively need to scale out genomic epidemiology. One part where I will disagree with some of the other panelists today's number of cases represents today's number of infections. It doesn't. We only catch a fraction of the infections. We also need to understand that today's cases don't represent today's deaths. The people infected today, today's confirmed cases, aren't going to have severe outcomes today. Patients start to, unfortunately pass away 2 to 8 weeks after symptom onset. So we need to recognize this time lag and realize that the people getting infected today are going to have severe outcomes some time from now. And if you only start responding when the mortalities or the hospitalizations start going up, it's too late. Think about how disheartening that is. Even after you start responding correctly, there's going to be a time lag until you see an impact of those interventions. So I think we need to be very, very close attention to the numbers. It is correct that we are testing more. It is correct that Maharashtra does have more transparent data, better ability to see the spread. But what we need to pay attention to is that if we don't respond right now, the spread is going to go on for some time. We absolutely can't wait till we start to see hospitalizations and mortalities go up. We're already starting to see a very rapid rise in the rate of mortalities and deaths. Preparing for the future is very important, but we need to respond right now. And one of the key things is research, right? We have such a paucity positive, high quality research. I worked on the Placid trial, which was one of the world's first trials to hit complete enrollments for convalescent plasma therapy. We found it doesn't work. We need more like that. Rapidly designed, simply designed, randomized clinical trials, so we can answer very important therapeutic questions. When you look at recovery trial in the UK, that's answering so many therapeutic questions. So when we build out our healthcare systems and we want them to be resilient, we also have to build them to be able to answer important clinical therapeutic questions very rapidly for the next pandemic, so that we don't waste too much time focusing on drugs like HCQ, doxycycline, ivermectin. We need to identify the ones that work, like the immunomodulating drugs, have the capacity for monoclonal antibody based therapeutics in our country. And we need more research labs like biosafety labs 3 and 4 to be able to respond and do research and train the class of healthcare workers, researchers who can work in these labs. I think the areas that we really need to focus on are wastewater epidemiology, genomic epidemiology, and data analysis. So I think if we start to do these things and work on making healthcare more inclusive and everything that goes with it more equitable, we'll be we'll be better prepared for the next outbreak, and there will be another outbreak.
Thank you, Dr. Swapnil Parikh. It was a fantastic summary by all the panelists. I think some of the issues that I think we need to underline, are we need everyone to participate. The government alone perhaps cannot do it. We need people to be aware. We need people to participate. We need corporate sector, various stakeholders from the city to participate in it. We need better research, better data management and data sharing system. We also need perhaps to utilize our resources better. Whatever is allocated, whatever is spent, there has to be a better accountability in terms of making the health system more equitable. Because at the end of the day, we are in any emergency dealing with only the symptoms. If you look at health in general, then it requires a much more intensive, much more sustained effort. Because the question that some of you are raising is that why, at the end of the day, we are raising the question of resilience, for instance. What does it mean? Does it talk about people's capacity to endure, or does it also talk about strengthening system and processes, location? So these are all extremely important questions. I thank you everyone for giving your valuable time. I know you are extremely busy in your everyday life. Dr. Bhansali, Dr. Ansari, Dr. Parikh, and Mr. Dighavkar. I'm really thankful for your time and your insights. I hand it over to Dr. Neville Mehta for the last words. I was delighted in discussion. Thank you, everyone. Thank you.
Thank you. Thanks.
Thank you, everybody. What a delightful exchange of ideas and thought processes. They too are very, very happy with what they have heard and what they've learned. Arun, thank you for moderating this session. So first of all, let me thank all the panelists, right from Dr. Gautam Bhansali to Mr. Dighavkar, Dr. Parikh, and Dr. Ansari for an excellent participation and response. Thank you for sparing your valuable time to be with us this morning. I must also specially thank Arun. Arun, you've done an excellent job of moderating, and you have also given your thought process. So thank you once again, Arun, for doing such a excellent job for us all over here. What came out very important was participation of the public-private participation. That came out very clearly, and in all respects, whether it was Dr. Bhansali or Dr. Mr. Dighavkar or Dr. Ansari, and of course Arun is part of this model, and of course Mr. Dr. Parikh also mentioned that yes, there has to be a lot of participation and interaction and communication, and Mumbai First is one such excellent model of a public-private partnership, which has worked for last 25 years towards achieving this. So those of you who don't know what Mumbai First does, do go to our website and check us out. And if there's anything that we could work together, we'd be too happy to work together. Once again, ladies and gentlemen, thank you for participating. I must thank the participants who have joined us. I must thank the press who has joined us. I must thank Free Press Journal who has reported our work and also publicizing this discussion. Also thank Dr. Armida and our executive board member, Mr. Ashang Desai, who has been with us from morning and who have helped us curate this panel discussion. And most importantly, I must thank my team of Mumbai First, led by Aishwarya Sontake and everybody else, including Ashwini, Deepak, and we have another Aishwarya with us, and of course Jennifer. I must thank all of them for putting up an excellent show and working very hard to contact you all and request you all to be a part of this discussion. Once again, ladies and gentlemen, please be safe. As it says that Mumbai is resilient, but we still need to do a lot of other work. So keep safe, keep your closed ones happy, and engage with each other so that we can continue to provide good health, safe health, and happiness all over. God bless you all, and thank you once again.
Thank you.